thank you for the wonderful opportunity to speak at this excellent meeting. It's a great privilege and honour. I'd like to talk to you about the challenge of only eye surgery. About 25 years ago, I decided I wanted to specialise in operating on people who only had one eye. I'm a glaucoma specialist, and I've operated on many thousands of eyes. And I'd like to share some of my experience with you. I'm very mindful that I'm speaking to a very experienced audience, and we only have a short amount of time. But what I hope I can do is share some clinical pearls and some of the lessons that I've learned along the way with that journey. So an only eye, you could define it as an eye where the vision in the fellow eye is less than 360. It may be that the patient feels that is their only functional eye. And it may be that the patient feels that loss of that only good eye would be life-changing with a profound impact on their life. A lot of what I'm going to talk about today will be available in 2 British Medical Journal open access papers. And for those people who are interested, who do a lot of only eye surgery, there are 2 papers that I'm going to focus on. One is the experience of surgeons who do only eye surgery, and one is the experience of patients who undergo only eye surgery. And these are qualitative research papers where we listened to surgeons and patients involved in this type of surgery. And for me, as an only eye surgeon, there are really 3 main patient groups. The first group is relatively straightforward, where there's only one good eye, but it's anatomically and functionally a normal eye. For example, if the fellow eye was lost through trauma. Then the second category is loss of fellow eye from an advanced disease like glaucoma, where the good eye may too have advanced disease. And finally, there's the third category, where the fellow eye was lost from a surgical complication, such as malignant glaucoma. And understandably, the patient would then be terrified of undergoing surgery on their only remaining good eye. I'm going to talk about 3 things: safety, surgeon experience, and patient experience. And I'm going to go through at great speed, but perhaps if there are any questions, I'd be delighted to answer them at the end. So let's talk about safety. For me, only eye surgery is all about safety. In 27 years of doing only eye surgery, I have lost one eye, one only eye. And it was devastating for the patients. And I have to tell you, it's pretty devastating for myself as well. And I have my checklist. Now, this is not an exhaustive checklist. This is assuming that all the basic stuff has been done. Things like risk of corneal failure, risk of retinal detachment, all that kind of stuff. But then this is what you're left with. So my first point on the checklist is consent. And this concept of material risk. That risk in only eye surgery, the material risk is the risk of losing the eye completely, and making sure that's communicated to the patient and their family and loved ones who may end up looking after the patient if there is a disaster. Then I'm going to quickly scoot through infection, bleeding, wipeout, malignant glaucoma, severe hypotony, decompression retinopathy, uveal effusion, and tissue shortage and melting. And so for each patient I operate on, I run through this checklist and make sure that I've addressed each of the risk factors that could lead to loss of an eye. Let's start with infection. Some of the bugs that we get can be absolutely devastating. You've got streptococcus shown here. We've also got to be prepared to fight against Pseudomonas. And endophthalmitis is a devastating complication in only eye surgery. And I think we're relatively good. If you look at this top center, we're relatively good at picking up people at high risk of endophthalmitis. The top center picture is a man with severe destructive atopy and chronic colonization of the conjunctival fornices, the lid margins, and the skin around the eye. And there's a very good pearl here from someone called Frida Sai, who would always say, you can't win in the eye if you're losing everywhere else in the body. You've got to get this sorted first. I also think we're very good at picking up blepharitis and nasolacrimal obstruction. You can see there. Perhaps what we're not quite so good at is some of the systemic risk factors that influence infection. And these are getting more and more common as we have more elderly patients. You've got an infected leg ulcer there, which looks nasty, and terrible dentition on the bottom right photograph. Now, this terrible dentition is releasing chronic bacteremia into the bloodstream. And if, like me, you're a glaucoma surgeon and implanting devices, maybe it's a Barvell tube, a Paul tube, any kind of device, even an intraocular lens, you don't want transient bacteremias because they can settle on the implants. And in fact, the only eye that I lost was because of a man who had severe infected dentition. He always kept his mouth closed because he was so ashamed. So now, before I put a tube into anybody, I always get them to open their mouth and look at their teeth. Get your teeth fixed first. Bleeding, suprachoroidal hemorrhage. This picture on the left here is taken from just this week, where one of my colleagues had an on-table suprachoroidal hemorrhage. It was well managed, as you can see, and just stopped it from going into the macula, millimeters away from disaster. And my pearl for suprachoroidal hemorrhage is think systemic. I've just written a book on the systemic challenges preoperatively and how to manage them. And I think that's a really important thing to think about. Is the patient on anticoagulants, NOACs, other drugs that interfere with platelets? Have they got a bleeding diathesis? Did they have a severe bleed when they had dental work or when they had a prostate operation? Take a good history. Do they bruise? And think about herbal remedies. Remedies such as ginkgo biloba are as potent as NOAC drugs, and patients don't tend to mention that they're on herbal remedies as part of the drug history. Wipeout. Wipeout is more common than people realize. We all know about the glaucoma patients with split fixation on their visual fields with reduced acuity. The glaucoma patient with reduced acuity is a dangerous beast. And here you can see a trace from general anesthesia, where during general anesthesia, there was a precipitous drop in the blood pressure and the patient wiped out and woke up with no vision. This patient was sent to me from elsewhere, and every 2 or 3 years, I'll be sent a patient like this who's wiped out through general anesthesia or through a too high volume of local anesthesia in the orbit, maybe without hyaluronic hyalase during local anesthesia. Next one, we don't want to get malignant glaucoma. Now I'm going to return to malignant glaucoma in a while, but don't forget, these are the eyes with anatomically short axial lengths. It's always helpful to have biometric data when you're operating on only eyes. The eyes with microcornea, tiny eyes, deep set within the orbit. Maybe they've got angle closure, maybe they haven't, but get some biometric data. Hypotony. What are we going to do about hypotony to prevent that? Well, first of all, we've got to identify eyes that are at high risk of hypotony. These might be aphakic eyes. They may be eyes with pigment dispersion syndrome. Patients with atopy are very prone to hypotony. They might be very large eyes, such as high myopia or ophthalmos. They may be eyes with an abnormal connective tissue problem. So I always get the patient to put their thumb against their wrist. And if a patient can put their thumb against their forearm, they may have hypermobility. If their kneecaps dislocate or they've had recurrent dislocations of their shoulder, think connective tissue disease. Then think about nutrition. We want to prevent wound leaks. Many of our elderly patients are just taking meals out of the fridge or out of the freezer. They don't have a good diet and are scorbutic, for example, with low levels of vitamin C. Remember that we can use doxycycline orally as an anti-collagenolytic agent in patients we think are prone to wound leaks or who might not heal well. And I'd apply that even to cataract surgery. I put the bottom right picture on to remind us all that choroidal effusions start on table. So we don't want to have hypotony intraoperatively. We need to control the intraocular pressure even during surgery. Decompression retinopathy, simple and devastating. It's largely under the surgeon's control. Use your method of anesthesia, use your first entry into the eye very controlled to make sure you don't have decompression retinopathy. Shouldn't really happen in the modern era. Then we've got uveal effusion. Now, uveal effusion is incredibly dangerous. It doesn't always come with a label. So we know that very short eyes, for example, nanophthalmos, 20 millimeter axial length or less, we know that these eyes are prone to uveal effusion. And we can measure posterior scleral thickness, more than 1.6 millimeters being abnormal. We can look for choroidal effusion. We can look for supraciliary effusion on the UBM, which is the earliest sign of uveal effusion. These eyes are dangerous. They're often small eyes, deep set within the head, and they have this anomalous vasculature from elevated episcleral venous pressure because the eye is jammed in the orbit. These eyes are very dangerous. And I would say, if you're going to lose an eye, uveal effusion, if it's missed, is a real problem. And remember, there are two types of uveal effusion. There's nanophthalmic uveal effusion with a very short axial length, but there's also uveal effusion syndrome, where there might be a normal axial length of 23. But in each case, you have thickened posterior sclera and other signs of uveal effusion. Finally, melting and tissue shortage. Very important if you're putting hardware like a Barvelt 350 tube into the orbit. Always check for tissue mobility and very thin tissue and tissue shortage. If you can't evert the upper lid, you've got tissue shortage. If you've got cicatricial change with loss of canthal anatomy, you've got tissue shortage. And if you've got uncontrolled atopy or systemic vasculitis, you're at risk of wound melting. All these things, you can lose eyes. So that was a very brief overview. I could love to talk for an hour on each one of those. But if you cover all of those domains, all of those elements, you're unlikely to lose an eye. I'm now going to talk about surgeon experience. I've got to that stage in my life where I'm training younger surgeons to do only eye surgery, and I want them to be resilient. So the paper in the British Medical Journal, for those of you who do or train only eye surgeons, is very important. How do you increase their skill levels pre-operatively, intraoperatively, and post-operatively? And I think all of us as experienced surgeons have a duty to share our knowledge. What support networks do those surgeons have in place? They must not be isolated. What training are you actively doing to help your young surgeons on that journey to do large numbers, tens, hundreds, thousands of only eyes? How do you get them comfortable doing that? It's all within the paper. How do they cope? How do they survive the stress of doing these eyes day after day after day, perhaps when things don't go wrong? What techniques can you use, such as visualization and faith, to help you get through this journey? And finally, losing an only eye. From personal experience, I can tell you it's devastating when you lose the only eye of a patient. And we need better support networks to help our young surgeons, because if you do enough only eye surgery, there is a 100% probability it will happen to one of your patients and to you as a surgeon. And most importantly, we need to create a culture where surgeons want to do only eye surgery. So we have to have a no blame culture, a learning culture. And remember that adverse events in theatre impact on surgeons as well as patients. So for example, there's a great paper in the British Journal of Surgery here, The Impact of Adverse Events on Surgeons. And this paper, for the first time, articulates how adverse events for patients can actually damage the mental health of surgeons. It's a very important piece of work. And I also have, for my young colleagues, a burnout checklist and 3 domains of how to avoid isolation, how to enhance their well-being, and how to build resilience. And you need to look at all of these things if you're going to be a surgeon doing huge numbers of only eye surgery. You need to be at your best the whole time. There are lots of resources to prevent burnout. The American Academy Physician Burnout webinars are excellent. And the Royal College of Psychiatrists in the UK have a brilliant survival guide, which is very applicable to surgeons. I'm going to finish with some of our work, again, published in the British Medical Journal, on patient experience. How can we make that experience for patients undergoing ONI surgery better? How can we understand the emotional impact it has on them, the fear, the depression, the distress? How can we understand better ways to help them cope? And how can we make that experience better by a more empathic approach? Let's imagine if there are hundreds of people on this webinar now. You know, some of us are going to end up having only eye surgery. None of us think we're going to end up with just one eye, but many of us will. So it's lovely to read the actual papers if you're interested in this area, to see what patients say about how devastating and how horrendous it is, how terrifying it is to undergo only eye surgery. It's a humbling experience to listen to. And post-op, what can we do post-op? Now, in some glaucoma operations, we have to patch the eye in the sense that we need to protect the corneal epithelium, because if the epithelium is a bit dodgy and it falls off, you then can't use post-op steroids and you're into kind of melting situations. So sometimes we have to pad and patch the eye, but how can we make that journey better for patients undergoing only eye surgery? And we have lots of suggestions within our work. So I'm going to wind up there in case there's any questions, but my advice for those of you who do huge numbers of only eye surgery, who want to, or who want to teach only eye surgery, is have a kind of checklist. Have something that you look at meticulously so that the risk of losing an only eye will fall well below 1 in 1,000. And then we can reassure ourselves and reassure our patients truly that the risk of them losing the eye is minimal. Thank you very much indeed.
Thank you, Peter. If you can stop sharing now.